To start with, I'd like to say good evening to everybody out there in webinar land and take a second to genuinely thank everybody that's decided to share this hour with me. It's certainly not lost on me that this hour competes with a lot of other important things in your busy lives, whether it's finishing up charts for the day, perhaps family time, eating dinner, sitting in traffic, whatever it may be. And so hopefully I've put together a reasonable program for everybody out there, and everybody will have something to take home from it. You obviously have seen the topic. This is why you chose the presentation. We're going to talk about all ceramic restorations, odd topic these days. But before I go into that, even though Noah read the introduction and some of the bio about me, I feel like normally I'm behind the podium and there's a bit of interaction with the live audience, and that's my comfort zone. I've only done a couple of webinars so far, and so this is a little new to me. So I have training wheels on either side, and from my perspective, I think it's important for everybody out there to know a little bit more about me. So let's see if I can kind of fill in the gaps based on what Noah told you. As he said, I'm heavily involved in education. I wear a few hats, but this is probably the biggest hat I wear. I've been teaching at Pacific since graduation way back in '91, and I'm heavily involved in education. Even so, right from the start, I've been involved in private practice. I have maintained the private practice and still have it. I've been in San Ramon since '91, and I think it's an integral part of what I have to deliver to an audience, whether it's my students or somebody in a webinar or somebody in a live classroom. I think there's some validity that comes to the table when the audience on the other side knows that you're a wet-fingered dentist and you're still practicing. So I plan on doing that for as long as I can. You obviously know that I look at products, work with industry, constantly looking at new materials, new techniques, new deliveries, and that's a part of my job that I really like. It helps you stay on the cutting edge, and you're aware of all the latest developments. This is how I come to you, through Catapult and through a speakers consortium, and that's been a great thing that's been added to my career over the last few years, and I'll talk a little bit more about that shortly. And with the balance of the time, which there isn't much, but with the balance of the time, I try to spend it with family. I have a very understanding family that shares me with everybody else. First disclaimer, besides myself and whatever my biases are, I think it gives some validity and validates the message that I bring when people know I belong to Catapult. Just a few weeks ago, we got back from our annual retreat. So this group of dentists that I have kind of banded together with has been a really good addition to my career and the expansion of my career, in the sense that now I have a large group of folks that I can share and exchange ideas with. And the agreement was that everybody just puts their egos, checks them at the door, and we talk freely. So whether it's evaluating a new technique, a new product, what we think is happening in practice, I get to bounce off ideas off of other people, and they bounce them off of me. And so a lot of the message that I bring often has had the individual biases stripped away from it. And so what I like to say is I'm bringing the benefit of many great minds. I may be the one speaking, but this is generally a well-titrated message. And again, you're going to judge for yourself. In addition, I'd like to re-thank the sponsors for tonight. Obviously, Noah mentioned those, but Microdental and Doxa. In particular, sometimes the disclaimer about the sponsorship and the honorarium is a difficult message, and speakers quickly run through it as fast as they can. It's a very comfortable message for me. I have my own personal rule that I don't speak or endorse a product or an entity that I don't either personally use in practice and I'm committed to, and or we don't use here at school. And at school at Pacific, we have a very high scrutiny level. When we're introducing a new product, it's not just me, it's a handful of very respected clinicians that put it through the rigors and decide to use it. And so it becomes a very comfortable message. This is something that I would be talking to a dentist down the hall, a neighbor, a friend, and saying, this is what I do. So I have no problems, and it never feels like I'm up for bid at the highest bidder. A second rule that I have is, while many of these companies, when you're evaluating their products, are very generous and happy to share samples with you, my rule is once I've adopted a product, I insist on paying for it. And so I think that takes some of the mud out of the water. And these are products that I use, again, like I said, daily in practice. So let's get to it. Talking about all ceramic restorations. I think we'll talk about a few components, and there's a lot to fit in an hour. So what I'm trying to do is give you a 10,000 foot level of maybe how to triage when you're treatment planning, how to decide what material to use, and some helpful hints and techniques. To do that, see where we're going, we have to think about where we've been. All ceramic restorations have been around for quite a while, so we'll maybe look at some of the historical entries. But most importantly, we'll spend quite a bit of time on what's available now, what seems to be the popular restorations, and some of the benefits and disadvantages of these. We'll certainly spend a little bit of time talking about the lab, how you communicate with them, and what a lab like Micro, for example, has to offer. And we'll talk about tidbits. We're all wet-fingered dentists. I think the people are tuning in are. And so at the end of the day, everybody wants little bits of wisdom on how can I make my practice life more predictable, easier, make my restorations last longer, make my patients happier. First, just so I get a sense for the audience, if you wouldn't mind just chatting in your vote, if you can put either yes or no, and I'll quickly see that screen populated, I want to get a sense for who I'm speaking to. What I'm asking is, how many of you deliver all ceramic restorations routinely for anterior teeth? Okay, so getting quite a few yeses, and that's what I expected. I mean, it's 2013, our patients demand it, and while I've gotten a couple of no's, almost everybody's saying yes, and that's what I expected. Now, how about posterior teeth? Can you put yes or no regarding posterior teeth? How many of you deliver all ceramic restorations to the posterior? And that's looking like it's getting a little closer to 50-50. I would say 60-40, which means that the default when your patients are asking for something reasonably aesthetic in the posterior is typically the PFM. And so this webinar may serve as a springboard for some of you to consider branching away from PFMs. Not that there's anything wrong with PFMs, but hopefully it'll be liberating to where there's some confidence gain and some understanding that'll say, okay, there might be some reasonable alternatives in the all ceramic world for posterior teeth also. I just flashed a picture of a smile patient from practice. Obviously, you guys can look at this and the trained eye will see a handful of PFMs, whether it's in the front of the mouth, back of the mouth. They've been very good restorations, served us for a long time. They will be continuing to deliver these restorations, and they do have their shortcomings. We certainly will talk about opacity issues, marginal issues, gray bands near the gum line. So we'll show some clinical cases there. Next, and I'd like everybody to take an inventory in their mind, I'll throw out what are maybe some of the common beliefs about the benefits of all ceramic restorations. And in your own head, tell me or tell yourself, do you agree with this or disagree with it? Maybe I'll put some of the cautions that you have to bed. Maybe I won't. And I know some of these questions will come up later in the Q&A. But does everybody agree that we have a good chance of improving an aesthetic outcome if we eliminate metal? I think most people will agree that that probably is the case. Here's another big thing. We know, and this is documented, there's evidence of this, that biocompatibility goes up. We know that there's certainly metal-based allergies that exist, and no matter how precious the metal is, while that reaction decreases, the less there is non-precious trace metals in there, the better the final outcome, that there's certainly metal-based allergies, and depending on what study you read, these can be anywhere from, on the magnitude of 4-to-1 to 6-to-1 higher in women compared to men, but it happens in both. I'm here to tell you that you can deliver all ceramic restorations and not sacrifice anything with regards to marginal fit or seal. Not everybody's convinced of that. We certainly have the advantage of having partial veneer designs that can get their retention through the bonding mechanism. I mean, after all, this is how we bond a non-retentive inlay or onlay on the back tooth or veneer on the front tooth. We're really relying on modern science, modern adhesive principles, and bonding. We're not counting on the traditional retentive and resistant forms to our crown and bridge preparations. No doubt in my mind that patient satisfaction goes up when you meet their desires. And let's face it, these days patients want something that is more aesthetic. Their definition of aesthetic is not always equal to our definition of aesthetic, but it almost always means white rather than gray or gold or black. And another big thing, and this is more of a phenomenon over the last few years, the lab surcharges related to precious metals has certainly skyrocketed, and I know everybody that uses metal in their practice has noticed this. I would never advocate using a material that gives you an inferior product or inferior longevity or quality just for charge, but if you can deliver a restoration that the patients are happy with, that has a predictable long-term result, and at the same time you might save some lab fees, then I think that's potentially a win-win for all involved. Certainly through the ceramic world, we can take advantage of the digital workflow that's becoming more and more a part of our lives. So what are some of the drawbacks? See if you folks agree with these. Common reservations might be that all ceramic restorations are fragile. I have a bunch of question marks after that. We'll talk a little bit about that. This I completely agree with. They are less forgiving, and so success with all ceramic restorations is highly dependent on treatment planning. There's more and more materials out in the marketplace, and while some of them can satisfy multiple needs, when you're choosing a particular material, how to deliver it, whether you bond it or cement it, all these factors weigh in on the likelihood of long-term success or intermediate success or immediate failure. And so, just like the adhesive world, compared to the amalgam world, we could plug in an amalgam with our thumb and have a reasonable chance of it working. With adhesive dentistry or composites, there's a lot more technique sensitivity and there's a scrutiny to sticking to a particular protocol. Same goes with all ceramic restorations. Some people have to relearn the way they prep, depending on when you went through your schooling and what your default preparation design is. We have to modify from that. Everybody's got the hands and the skill set to do that, but they have to be made aware of what type of preparations work best with all ceramic restorations. A lot of people have concern about opposing wear. We've all certainly seen cases where a particular type of porcelain has done some damage to the opposing tooth structure. So we'll talk a little bit about that. And finally, and this is a biggie, if you are using your favorite lab, but it's a smaller entity, more of a mom and pop shop lab, they may have invested in all ceramic options, but they may not have every option available. And the bigger menu you have to go to, the more your options are, or the more likelihood you're going to choose the best option for a particular patient. So if your options are limited, you may be doing yourself or the patients a disservice. And this is where I really advocate for having a lab that can deliver a lot of variation. So think about what else you might have. And if there's other reservations, I hope I listed them all, but other reservations that haven't come up, certainly bring them up in the Q&A. Quickly go back. Historically, some of the metal-free options that have fallen out of popularity, there was the traditional porcelain jacket crowns, hand-stacked crowns, the fiber reinforced. Some of you that have practiced a while will remember the Targus Vectrus world. The Zirconia infiltrated resins, the wool cerams, which now we're revisiting, and that's a good topic for a different day. The hybrid ceramics, which are ceramics and resins mixed. All of these had transient popularity. They lasted for a while, but for different reasons they fell out of favor. One of the big reasons was their fracture strength. Some of these didn't have the best long-term survival records. We could get some of the most beautiful, beautiful restorations out of our porcelain jacket crowns, but at what cost? Many of them weren't on the tooth after 6 or 7 years. Many of the teeth became non-vital because of how heavy the preparations had to be. There was a wear in the reliability and the breakage. They were limited based on where the teeth were. Some of them were in load-bearing zones, and that particular material couldn't handle that load. We have answers to this now with our modern options. Some of the most common ones, we'll kind of do a little roll call of ones that are in practice now or standing the test of time, and many of you will recognize these names. There are the lucite glass ceramics, the Empress category, essentially. I'll refer to these sometimes by their category name, sometimes by their trade name or the most popular brand, so that it's easy for folks to recognize. There are these Zirconia coping supported ceramics. P to Z happens to stand for porcelain to zirconia or pressed to zirconia. That is Microdental's house brand. Lava, I'm sure everybody recognizes Procera. We can talk about the lithium disilicate, glass ceramics, e.max, a popular option that has really kind of begun to boom in the last 4, 5, 6 years. And now, even newer, we'll talk a little bit about the monolithic zirconia restorations, the Zeus crowns or the BruxZir crowns. And we'll certainly talk a little bit about combining these technologies. That's really where a lot of this is going, using the benefits that all of these restorative options have to optimize a restorative outcome. So we'll start with the first one, Empress. It's been around the longest. It's been literally a workhorse for us in practice. We have 20+ year data on Empress. Survival rates over 7 years in the 90th percentile, which will rival metal-based restorations. It's a pressable ceramic. Essentially, it's similar to the lost wax method of how we produce metal-based restorations. And because these presses were initially waxed, you can get excellent margins, very good seals. You can get very good aesthetics, and with the right technician and the right amount of effort, you could get phenomenal aesthetics. So these are a lot of aesthetic dentists' go-to restorations when they really have to deliver excellent aesthetic products for anterior zone for patients that are very demanding. The good aesthetics are when you have a monolithic ingot that you press. When you want to improve on that, often the technician's instructed to cut back, create some space near the areas that need to be characterized, whether it's incisal edge or proximals, and start to hand stack additional porcelain to customize it, as well as build in translucency and any number of things in those, as far as surface stain also. Empress is kind opposing to structure, and so that's certainly been documented and tracked over time. We'll show you some clinical samples. Here's a case that has both crowns and veneers present, and I don't think anybody will argue that that's not a very nice result. Here's a before and after case, and this makes a point very well. When folks wonder about the longevity of all ceramic restorations, we can look at this case, and you'll see veneers here. You can certainly tell that they're veneers because you'll see finish lines. The gums have recessed. And you'll see very good margins. I would say these are excellent margins on a case that's had veneers on it for 12+ years. The patient's interested in changing it now. Why? Well, because they've matured, the gums have migrated, they're seeing discoloration in the root down here. But what's the other big thing that they're seeing? More than likely, they wanted their teeth a little bit lighter. And we'll all see this phenomena. The teeth in the back, in the corridor are whiter, because now everybody's bleaching. And so a patient that had a set of veneers done a while ago, the gums have recessed a little bit, and they've chosen to lighten their other teeth, suddenly these veneers don't match. So while technically they are still successful in servicing, and I would say arguably a nice looking veneer, they're ready for a change. We can certainly go from this to this product, and you can see that the teeth are now made more youthful, essentially reverse time, giving them some mamelons, and it's what everybody's trying to do, look and feel younger. This is one of the keys with our more translucent ceramics that we work with. We really want to take the guesswork out of it. The benefit of an Empress crown often is its relative translucency and how it can draw color from the underlying tooth structure. With that comes a risk. What if we don't want it to draw the characteristics from the underlying tooth structure? Or what if we want to know what that influence is going to be? If their prep stump is an A2, there might not be a lot of influence. If their teeth are a little bit darker, there's likely going to be more. If the stumps have tetracycline staining, it's a whole new ballgame. If there's any tattooing from metal-based restorations or posts, or if it's an endodontically treated tooth, your technician needs to know that, because they can deliver a crown that's a color that you asked for, or a veneer that's a color you asked for, but if the influence underneath changes that final result, they're not to blame. We're to blame for not communicating that to them. So the beauty of these all-ceramic restorations are, if you communicate the stump shade to the lab, they can create a stump die that will sit underneath this restoration, and they can look at that restoration and see what the final product is provided. Is it the final shade that the doctor wanted? And we all know in dentistry, probably the hardest thing to do is match a single central to another central. We certainly have technicians out there that are very gifted that can deliver very good PFMs. If you reduce the tooth enough, hide the margins enough, consider a facial, butt joint, shoulder, we can certainly have a handful of technicians that can charge us $400 or $500 for a single crown, and they can get close to matching two centrals. So even in a magnified image, you'd be hard pressed to find out. But routinely, we're going to have a much easier time getting a crown, an Empress crown, for example, to match a natural tooth if we go with an all-ceramic option. It isn't as demanding or as grueling of a project, and I would argue that this is virtually flawless in this case. And the way the Empress process works is they're pressed out of ingots. So just like porcelain shades, the ingots are available in multiple shades and multiple translucencies. So certainly these can be pressed, or in today's chairside delivery world and the world of CERAC restorations and E4D restorations, there are CAD blocks that if you live in that world and want to produce Empress restorations chairside, that's also available both in high and low translucency options. So here's some samples of various hues of crowns that were literally out of a CERAC mill. When I show cases, I used to show my own cases, and it was at one point maybe feeding my own ego or whatever it was. But now I find it most gratifying to actually show some of my students' cases. It is typically very empowering for the audience that's listening to see that a second or third year student that's literally working on maybe their 10th patient can go from point A to point Z and deliver a product that I'm about to show you. Of course, everybody at home can do this. And so it's really just about having the information base and the knowledge. This is a patient that came into our clinic, and we had a good student, arguably one of our strong students, that inherited this case. Patient came in, and their goal was to replace these two PFMs. There was a little bit of recurrent decay, but make them look nicer and also take care of that tooth. So it's a 3-tooth case, which can be a lot harder than a case that covers wall to wall, all the teeth in the mouth. So the student did a good job of photography. We insist on that, and so you'll be able to see some of the students' pictures. Here's the occlusal view. You can see the typical characteristics of those PFMs. And what I'll draw your attention to is the tissue around the margins of these PFMs. This is what we're talking about. I can't remember if these margins were deficient, open, over, under contoured, but even if they were perfect, it's not uncommon to see this halo effect around margins, and we've all had that in practice, where we go to the neighboring area, same patient, same hygiene, might have very nice pink stippled tissue, and you come and feel your crown, and the margins are closed and flawless, and hardly detectable, and yet they have this zone around it. And that's based on that metal-based allergic reaction. And so here it is up close. This is after some curetting and cleaning up. The tissue looks a little bit better, and still it doesn't look like the area that doesn't have metal up near the margin. So the patient did their diagnostic wax up, did their smile design, transferred it to the patient's mouth. This is just an overlay of some acrylic, just to make sure that the patient was, or the student did this, make sure the patient was happy with the final contours. And this is just an overlay. There's no prepping that's been done up to now. Cut off the crowns and put temporaries in place. Put healing temporaries in place. And what I'll do is draw your attention to the tissue reaction already. With just bisacrylic temporaries in place and with the metal gone, the tissue's happier. The other thing you'll note is, compared to the pre-op, the gingival zeniths on the two teeth match now. So we simply did a little bit of laser gingivectomy with the diode laser to get the gingival zeniths open, because when the patient smiled at an extreme level, you could see the crest of the gingiva, and the two teeth didn't look symmetrical length to width. So that was a small, minor procedure that really determines this case being a B case or an A case. So at this point, there's a lot more scrutiny on lab communications. It's not a full veneer crown. It's not a gold crown. It's not a PFM crown that you send to the lab and say, please deliver a B2 crown to me or an A2 crown to me. For this to really be successful, you have to work very closely with your lab. Student took some stump shade photos. Often in the photos, they'll have one, if not multiple shade tabs in the photo. Whether you're communicating the shade that you want in the shade tab that you'd like your final product to be, or you're communicating what the adjacent teeth are, or you're communicating what the stump color is, the labs like to see that reference. Sometimes you want to choose a shade guide that is exactly the color of your proposed restoration. Otherwise, sometimes you might want to show a shade guide with some discrepancy so they have a reference point to start from. This is what you work out with your lab and your communication with your technician. But I can tell you in practice, almost not a day goes by that I'm not on the phone to Micro talking to whatever technician I'm working with on a particular case, because that level of communication needs to happen and a lab needs to welcome that for you to be optimally successful. Another thing that's very useful is a black and white photo. And in today's digital world, it's easy to snap a picture with your camera and literally go into your computer and convert it to black and white with a click of a button. The benefit of a black and white photo is that we can communicate value much more effectively. When you're communicating value, that's probably the single most important ingredient in success. If we are off a little bit with the base color, with the hue, we can get away with it often if the value is correct. But if our value is off a couple of grades, usually those restorations do not look good even if we've chosen the right hue, the right color. So the results, here's the before the pre-op, and here's the restorations immediately after you deliver it. You can see that the tissue is a little angry just from cleaning cement. This is not doctored up or a week or two later. This is literally what the tissue looks like. The tissue already started to heal around his temporaries, and it will continue to get better. So this is what a student that's probably before that point done 10 or 12 units of crown and bridge in his life, single units, posteriors, was able to deliver. Now, granted, there was a lot of mentorship and a lot of instruction by instructors, but if they can do this, everybody out there can do this. And we can pick this apart, and I would argue that it's a very successful case. We can certainly say that maybe there was a little bit of extra chroma, more than what was needed, built in here. But all in all, if you look at the beginning point and the end point, this is a very, very good case. And this part is the key. Before, when the patient raised to their smile, you could see asymmetrical gingival zenith. And I think the fact that you raised the gum line there really made the case better than it would have been without doing that. So now that we've kind of put Empress to bed, what are some of the shortcomings or some of the risks? Empress can be very fragile pre-bonding, and that's important to know. When we handle it, we certainly don't want to be too rough with it until it's bonded. It gets its strength from the bonding and the underlying tooth structure. That's what reinforces it. Once it is bonded, it's not considered one of the strong restorative types. I would call it intermediate strength post-bonding. And it's very important then, because it's intermediate strength, to know about the patient's occlusion, parafunction, and know that where you're placing this, you have the amount of tooth structure necessary removed so that you can get the depth or the thickness or bulk of restoration needed for success. You have to bond Empress restorations. We don't have a cementation option. Some of the materials that we're going to go through soon will have a cementation option. And Empress has an ideal restoration thickness window. So if it's too thin, it could be fragile. If it's too thick, conversely, it can be fragile. Much like our PFM restorations need that ideal thickness of porcelain in that 1.5 millimeter range, Empress has a similar range. If the underlying tooth structure providing support for the Empress is over-reduced and 3 millimeters away, just like PFMs that can have porcelain fracture, Empress crowns are more likely to fracture if there's too much Empress built on itself. And the more you cut that back, the more you stack, hand stack feldspathic porcelain, the more that risk becomes a reality. The translucency benefit that we talked about that makes these teeth look alive is limiting in the sense that if you have a darker substructure, Empress may not be your best choice. And our bonding protocols have very little room for error. Bonding is a very technique-sensitive procedure, just like with our composites. If we don't do it right, it won't stick, or we'll have postoperative sensitivity or a host of issues. And of course, the inside surface must be ready for bonding. So these have to be etched and silanated, and that's what they look like coming back from the lab. So now we'll jump into the Zirconia supported world. These are the P to Zs, the lava crowns, the Procera crowns and bridges. These also have a very long track record. They've been around for 15 plus years. The strength significantly increases because of the supportive coping that we have. Accuracy is certainly there. We'll show you some up close slides of margins. And now what was only available for single units in Empress, now we can do multi-unit bridges. And some of these frameworks now can literally be roundhouse bridges. We can have Zirconia milled frameworks that can go from second molar to second molar. They're not common, but they're done. Again, fair to good translucency, but we also have the ability now with that coping to hide a discolored core. On top of the Zirconia coping, we have a few options on what kind of ceramics we want to put on there. We'll talk a little bit about that. But suddenly in this class, some traditional cementation options are open to us. Here's a slide that I borrowed from 3M, and you can see up close how good of margins you can get with some of these milled frameworks that are in the 50 and often beating 50, approaching the 25 micron range. So these are very, very good options, and to some degree take out human error out of the equation compared to traditional dye trimming and waxing and burnishing that happens with metal-based lost wax methods. This is kind of 3M's glam slide, but it drives the point home. These are lava crowns or lava bridges, and what they're showing you is the relative translucency that even though we have a Zirconia coping, the relative translucency that's there. Here's a natural tooth. Here is a crown, PFM-based crown, and how it transmits light, or how it doesn't, other than the incisal edge with the porcelain. That crown was then replaced with a lava crown, and you can see how it very much mimics the way natural teeth act. In addition to that, and this is where it comes down to communication with your technician and the knowledge base that the technician needs to have, and this is one of the reasons I work with Micro, is that there are skilled people there that know this if I forget to communicate. If we have a tooth that's reduced beyond the ideal window, if we wanted 1.5 to 2 millimeters of ceramic here, but the tooth is reduced here, or that's how I found it, they need to build up, much the same way you would build up the thickness of a PFM subcoping, they need to build up the zirconia here. So with their digital wax knife, they may have a thin coping in this area, but they have to build up the support for the added overlay of porcelain. If this is not done well, we're at risk for fracture, same way we would be with PFMs. And so this is where we really rely on the knowledge base that the lab has and the fact that they routinely do these restorations so you won't have surprises. Here's an example of a zirconia-based 3-unit bridge. And this is what we were talking about. These can be made relatively translucent and or opaque, and they can be tinted. So if I am doing a single crown and I need the influence of an A3 or an A4 base shade to come through, because that's what the natural teeth in the area look like, I can have that warmth shine through the overlay and make it look like the other teeth that are present. Often you have veneer cases and the single tooth fractures, now you need a full crown. For the durability of that crown, you may need to create a coping-based system, but I need to then get my coping to match the stump shade of whatever existed on the adjacent teeth. And so this array or selection is important to have to really get optimal results. And in the hands of a gifted technician, there's lots of possibilities here. Here's combined technologies where there is a zirconia coping, but they've actually pressed Empress to that. So it's the same Empress ceramic, beautiful detail, but they've reinforced it with zirconia. Here's some lava crowns, and this is just straight out of practice, a Procera crown on a solid model, and you can see What a nice job they've done for simple single posterior restoration. Multiple units are possible, and because the Zirconia framework provides a support, they also choose to put e.max, which we'll talk about next, over the top of it, stronger ceramic. So there's not a lot of limitations here. You still need a lot of reduction. Just like PFMs, you need 1.5 to 2 millimeters of reduction in load-bearing zones. The traditional principles of prep design, retention design can't be ignored. These restorations are a little bit more rounded. We'll talk about that, but they can't be ignored. And internal adjustments to copings are more difficult. They're sometimes recommended against, but if you do them and you've got a material that you feel comfortable doing that too, and you want to follow manufacturer's specs, you want to make sure you do it with lots of water and a fine diamond. Ideally, you would often make adjustments to the teeth. First, ideally, you would make them because the impression accuracy is there and the fabrication accuracy is there. But if you do have to, sometimes you would actually make it on the tooth rather than the crown. Again, the coping minimum thickness, similar to a PFM, it gets to 0.3 of a millimeter. So the next big thing that came along is e.max, and this was a game changer. Ivoclar brought in e.max, or brought back Empress 2, for those of you that remember that, with some modifications. And now suddenly, a lot of the benefits that were there from Empress are available, but a lot of the liabilities went away. This is monolithic lithium disilicate. It is pressable just like Empress was, or millable through a CAD machine. Again, you have high and low translucency options, but the indications suddenly start to go to the back teeth. Because this material is stronger, we can put it on teeth that have a higher load. The same great aesthetics that we can get from Empress, but now suddenly we went 2.5 times higher with the flexural strength. Depending on the translucency or opalescence we want, we can choose our ingot or choose our block and mill it with high or low translucency, and this is really designed to replicate natural tooth structure. Again, very good wear rates. So we're not worried about these restorations wearing down the opposing tooth. They just don't, and this has been studied over time. This hasn't been around as long. It really started to take hold, I'm going to say 5.5 years ago or so, but very, very high success rates over the initial 4-year clinical trials. Very strong when it's monolithic, but just like Empress, if it needs to be customized, it can be cut back at critical areas like incisal ledges and additional characterization added, but you slightly reduce the strength at that point. But here's a perfect example, a lingual view of a bridge, and you can see the marbling that's happened, the beautiful translucency that's there, all the customized staining. Really, the sky's the limit. Here's a simple traditional posterior crown out of e.max, kind of an on layer, a 3/4 crown, and a nice European crown. It's kind of a joke, but we all know that in the States, people want to go with wider and wider teeth, and the sign of a good technician, a good dentist in Europe, is how natural you can make it and how you can put the stain in. So really, depending on what you want, this product can deliver. Now, this may be overkill, but you can see how beautiful this inlay is. This inlay is really a glorified ceramic sealant, right? We don't do these very often, but if you have cause to do it, you can see the detail that a skilled technician can deliver to you. What are the limitations with e.max? You're still going to need a fair amount of reduction. This is the same as the other ceramics discussed up to these areas. But this is in load-bearing zones, so in posterior teeth with heavy occlusion. We can get much thinner than this. And so if I'm doing micro veneers, not necessarily no prep veneers, but very thin veneers where I'm taking away very little tooth structure, I have delivered e.max at 3 to 4/10 of a millimeter. It's a little bit more fragile pre-cementation, pre-bonding during the handling phase, but once it's bonded, this is certainly a very predictable restorative material. And so you pick and choose your battles. If it's a patient with good anterior guidance, with no parafunction, no wear facetting, and you're putting this on a premolar, by all means, I routinely do not reduce 2 millimeters off of that tooth. I tend to be more conservative and respect the tooth structure there. So I will go as low as a millimeter, and like I said, sometimes in veneer cases, half of that. You still need a coping system for this if the bridges are longer than 3 units. e.max advocates up to 3 units in the anterior without a coping. Part of this was the downfall of Empress 2, also lithium disilicate. So my recommendation would be off the cuff that you still use e.max for single units, and as soon as you have any kind of a bridge framework, consider putting a zirconia framework in, and try not to ask too much of this material. It's just better to hedge your bets. The strength that we talk about, though, however, also equates to a much more difficult removal process, and this goes for a lot of these ceramics. Empress is fairly easy to cut off. For anybody that's had to cut off any e.max restorations or zirconia-based restorations, it can be done, but you need some different armamentarium, special diamonds, and you don't rely on the flexibility of metal and the way we spread crowns traditionally. You have to have a different approach to this. But really, that's about it. This is a very universal ceramic. Finally, we're going to jump into the monolithic all zirconia restorations. Zeus is Microdental's house brand. It's the type that I use routinely. Familiar brand that you'll all recognize as BruxZir. Now we're talking about a very strong material. Strength is jumping way up there. Very, very strong, even at a millimeter thick. I'll tell you that I'm doing restorations on second molars on tight clearance areas where I sometimes only have 3/4 of a millimeter. And they are clinically performing very well 2.5 years out. It's a perfect solution for those worn teeth, heavy grinders, back teeth, not very tall, don't have room to reduce. You want to preserve as much of the natural tooth structure that they have left. Certainly multiple units and bridges are options with this material. And again, the fear is the stronger the ceramic gets, the more dangerous the opposing tooth structure. Anecdotally, what we see in practice, as well as some early studies, are starting to show that the wear rates of this opposing enamel is as or more favorable than some of our traditional porcelains. This is a great one if you haven't seen it. It's on YouTube. It's kind of Glidewell or BruxZir's advertising. This is their hammer test. This is a PFM that they're about to beat into the log there, the 2x4. And of course what happens is that the ceramic crushes and goes everywhere. The metal underneath is squished like an accordion, and your crown hasn't survived. You're going to do the same thing with the monolithic zirconia crown. This is the part that's pretty neat. It basically just becomes a nail. So even with that level of force, and I've done this, I've had crowns all on the floor, and you're worried about what happened to the margins. That's really nothing. Then I've had reps put these crowns on the floor and step on them with the heels of their shoes, and they can't break. So you can see that the margins are essentially unscathed, and this just became a nail that they ground in. So I stole this cover slide from Glidewell just because it does a good job of showing some of the differences, but I added some questions to it. We'll talk about this. These are typically the options that we have when we talk about crowns on posterior teeth. I asked the folks out there, which one do you think has proven strength advantages? I would argue that all these restorations are strong. I would say that the data says that the solid zirconia crowns are the strongest. Certainly, it eliminates technician error. While we can get gold crowns with beautiful margins, there was the possibility of error in the sense that a die could be over-trimmed, under-trimmed, a margin could be over-polished. Solid monolithic zirconia crown is impervious to this. The process is going through a milling machine, and as long as the impression is accurate or the digital scan is accurate, the crown should fit. After that, it's much more resistant to finishing errors. If a technician spends a little too much time on the margins polishing it or finishing it, they're not going to under-reduce that margin. It's going to take a lot of effort, and so you're less likely to get under-contoured margins. I can close my eyes and feel these margins with an Explorer, and they are virtually undetectable if I've given my lab a good impression. Which one requires the least amount of tooth structure? I will tell you that the zirconia crown does. The PFM in this case, on short teeth in the back, is out of the question. I just feel like I am taking away too much tooth structure, and I want to respect what's there. I'm hoping to leave more tooth for the next doctor that has to restore this the next go around. Gold crowns have a little bit less reduction, but typically we need at least 1.5 in functional areas. But like I said, we can definitely survive with 1 millimeter, and off-label, I'm doing less than a millimeter reduction on some of the really short teeth. Certainly, the solid zirconia crown in this day and age will have a lab fee that virtually will cut in half or a third, depending on the weight of metal from the other two options. And the ultimate test, which one is the one the patient's going to like in their mouth? Arguably, these monolithic zirconia crowns can be a little opaque, but we have answers to that. And at the end of the day, when you compare that to something that is gray or yellow, they're always going to opt for something that looks white. So it's pretty obvious this patient, I mean, this is a litmus test. Here's a patient that had 2 PFMs delivered. You can tell by looking at their arch that they're not kind to their teeth. You can tell that they have some wear issues. This has gone beyond wear. They have some parafunction that's taken away enamel, but now there's probably an acid-base erosive process that's going on also. These guys used to be PFMs here. Beautiful margins, no recurrent decay, but I think we'll all agree that the restorations are a failure. You're not going to see that with a zirconia crown or monolithic zirconia crown. What are the drawbacks? Again, especially when these are thick, this is very hard material. These can be very difficult to cut off, so you have to have the right armamentarium to do that. You must return this to a high polish. So, like I said, they are kind to opposing tooth structure if you have the original polishing glaze from the lab, but the minute you have to do any kind of occlusal adjustment on these, you have to have the tool set to bring these up to a high polish, otherwise all bets are off. And the opacity can be a little limiting, and that's why we use these less in the anterior. Here's a before and after. We can certainly see that compared to this person's natural teeth, these crowns are more opaque. But this is magnified direct vision. If you show a patient in the back of their mouth, they're going to choose this far over, much quicker than choosing something that shows metal. I showed this because we talk about bringing these back up to high polish. This is products from BruxZir Corporation. They have some polishers because traditional all ceramic polishers don't work as well. You can use them, but it's nice to buy a zirconia polishing set, and they have a very good one that can go through the different grits of the stones and the wheels to really reestablish polish. Now, they took an unpolished one and brought it, for demonstration's sake, brought it to high polish as if this was a glazed vinyl crown. But the point being, it's important to bring one of these restorations back up to a very high polish if you've destroyed that. And then the answer to the Esthetics. This is an example of a couple of products available from Micro. This is their Zeus Essential Monolithic Zirconia Crown. They have the ability to cut back just the facial portion of this crown, just out here on the buccal. Cut back and press or stack ceramic to that to give it a more lifelike appearance, but yet leave the occlusal table as monolithic zirconia. So we can now do a light reduction on the occlusion on a tooth that's short or in the back of the mouth, but we can customize the facial aspect of it. So now suddenly pretty nice bicuspids are in the equation. I hesitate to use something like this in an anterior tooth, but now suddenly it's not just for second molars anymore. Here's an example of a very nice result. This is just monolithic zirconia. It's a screw retained crown. And I think we could all argue that that's a very good product. So let's quickly review a little preparation design. While we depart in some ways from traditional metal-based restorations, it's still, we can't throw those concepts away. We have to think about retention form, resistance form, but typically these restorations are a little bit more rounded. We want to avoid sharp internal line angles. We want to create buffering zones for the ceramics, especially for the more fragile ceramics. Also in the digital world, sharp line angles and internal point angles are harder to read or scan. Margins tend to be more uniform. We're not having necessarily much heavier reduction on the facial compared to the lingual. And often we're really talking about a rounded, modified shoulder, which is rounded on the inside and it's heavier than your traditional chamfers. So this is a quick cartoon from our book, but on the left you're going to see the traditional PFM design with the very flat planes and sharp point angles, and on the right you're going to see a rounded all ceramic preparation design. Here's one of our teaching blocks or models, and these are veneer preps. but you can see how fluid the internal angles are, the relative amount of reduction, and how well refined these preparations are. This is what we use when we're teaching the students and kind of generally giving them some tips on how to prepare these teeth. Again, some other samples of teeth, a full crown, some veneers on bicuspids or partial veneer crowns on bicuspids. So how do we get from point A to point Z? Let's quickly take you through a bonding step-by-step procedure. This was a crown, just an e.max, I'm sorry, not a crown, an e.max inlay onlay delivered from Myco to the office. Tried it on the model. I have a little bit of Teflon tape that helps me pull that off. For those inlays that are tough to get out, this is a helpful hint. You can see it on the model and pop that Teflon tape out. It comes out. In the mouth, I'm going to start cleaning away the temporary cement, taking the temporary out. That's a wedge from Triodent. It's got a hollow triangular interface that sits over the papilla. It's a great way. Right now I have moisture control through an isolite that's there, as well as an Optrogate, essentially a lip retractor. But that wedge really will stop any bleeding or crevicular fluid. And the way it sits into that contact, it allows the restoration to seat without butting up against it. Here's the intaglio surface of the onlay, and we expect to see this frosted, chalky appearance. That's good. That means it's one that's been conditioned. However, what I'd like everybody to do is look at these closely with their loupes before they decide to go with it. Look at some of the areas around the margins. To me, that's the most critical part of a restoration. Guess what? Those haven't been conditioned as well. Maybe the hydrofluoric acid didn't sit here the same way that it sat there. In either case, that's a definitive portion of the margin. That's where the rubber meets the road, and that's where I need to have the best bond. And so be aware of this. Know when you might need to go back and re-etch this with hydrofluoric acid. After we've etched that, now you can see a different frosted pattern. The entire restoration is ready for bonding. Silane's applied. I have a handy little grip tab or a handle that allows you to handle essentially these little trinkets or bits of jewelry that we have to handle. We've all tried to handle a small lower anterior veneer or these inlays or onlays. This makes it handy. Teflon tape on the adjacent tooth to keep us from bonding to that. Selective etch protocol. If you're using 6th generation, you're just etching the enamel, or if you're using 4th or 5th, you're etching the entire thing. It's important for the dentin not to be etched more than 10 to 15 seconds. The enamel can be etched longer. That's why I always apply to the enamel first. Choose the cement of your choice, the bonded cement of your choice, and final restoration in place. For a posterior tooth, I think that's a very good service. We're giving a very dependable, reliable product that will last a lot of years with immaculate margins, good aesthetics, and the patient's going to be hard-pressed to find that restoration even in their mouth. The nice thing is we were able to save a lot of unscathed lingual and distal buccal enamel that otherwise didn't need to be prepped. So how do we decide whether we bond or cement something? And I'm going to go a little fast because I want to get to probably one of my favorite products right now in practice, which is the cement, my default cement that I'm using. Does the restoration, like an Empress crown, need to be fortified with bonding, or can we go with traditional cementation protocols? That's one of the questions. Does the prep have natural retention form? Can we cement it traditionally, or do we count on bonding technology to hold it in place? What do we think about, as much as we like to think our restorations last forever, what do we think about when this restoration has to be removed? And also, is biocompatibility important? If you look at the marketplace right now, this is roughly the breakdown of what folks are using. 38% are using the resin-modified glass ionomers. 34% are using the self-adhesive resin cements. So this would be the world of Unisem, for example. This would be Fujisem. And then the bonded resin cements, like the example I just showed you with Nexus. What I'd like to share with you is probably one of the latest product entries that's really gaining a lot of traction. It's a very intriguing cement, and it literally has become my default or go-to cement in practice. And this speaks to our our second sponsor, Doxa, and their product, their singular product right now. They create other things in Europe, and they have products in the pipeline, but they've literally entered the marketplace with this product, Ceramir. Uses NIB technology, nanostructurally integrated bioceramics. And the characteristics are that it uses some of the principles behind glass ionomer, but adds calcium aluminate technology. Creates what's very unique to the cement. It's the only cement that creates a basic environment. We're used to acidic environments with our cements. So there's none of the shrinkage that's related to resin and bis GMA. That's a first. And I'm going to say zero postoperative sensitivity. Not reduced, zero postoperative sensitivity. I use this cement on my patients, the ones that you just look at and their teeth are hot. I've been able to cement restorations without any anesthetic and not a peep out of them. Very good retention, rivals or beats all their competitive products. Extremely low film thickness, so you're never going to have difficulty seating or driving a restoration to place. Very easy cleanup. And probably the most intriguing part of this is the interaction, the bioactivity, and how the cement works to form nanocrystals at the interface. Essentially, in layman's terms, we're growing the cement to the tooth, or growing the crown to the tooth. So here's up-close microscopic slides. You can see how the ceramere is interacting at the interface with the dentin or the enamel, and how they essentially are becoming one through the apatite and the nanocrystal formation. So what's appealing about this? It's very forgiving. It's got a moisture gradient that accepts a little bit of moisture, a little desiccation. It's not as technique sensitive. There's not a lot of steps. You don't have to put primers on. You don't have to etch the tooth. You don't have to put conditioners on. So it's very easy. Simply activate the carpio, triturate it, and you're ready to squirt in. Indicated essentially across all of the lines of restorations that don't need bonded resin cement fortification, like the thin e.max crowns and or the Empress crowns. However, as of 2013, they've also gained FDA approval for e.max. So because of this, it's become my go-to cement. You know, if I have a cement now that matches or beats all the mechanical properties in the self-adhesive resin cement world or the resin modified glass ionomer world, is less soluble, has great compressive strength, and has less film thickness, but I can start to get bioactivity at the tooth interface and deliver a restoration that will, in all likelihood, potentially be there longer and be karyostatic because of the way it interacts with the tooth, I feel like I'm doing a big favor to my patients. Time will tell. You know, we trust a lot of the science behind this. I've had restorations in the mouth going on 2 years now and zero problems with it. But by definition, when you have a new product, while this class of products has been tested, it's a little bit of wait and see, but I love the fact that it eliminates the sensitivity that's there, and it's so easy to deliver. So I'm going to say when I first tread into there, I tread in the water carefully. I started to do a few restorations, had good success. Now, other than the restorations that truly need to be bonded, this has become my go-to cement.